In this video, we will discuss ectropion. Ectropion refers to eversion of the eyelid margin leading to exposure of the conjunctiva and cornea, causing irritation, watering, and cosmetic deformity. It most commonly affects the lower lid. The most common symptom is watering because the punctum is no longer opposed to the globe, impairing lacrimal drainage. Exposure keratopathy, chronic conjunctival inflammation, and cosmetic disfigurement are other effects. Ectropion is classified into involutional, cicatricial, paralytic, and mechanical ectropion based on the underlying mechanism causing lid eversion. Involutional ectropion is the most common type and is caused by age-related lid laxity. It primarily involves lower lid. Multiple factors act together in ectropion, but horizontal lid laxity is the most important contributor. Other factors are lateral canthal tendon laxity, medial canthal tendon laxity, and orbicularis muscle weakness. The clinical features are epiphora, red exposed conjunctiva. In chronic cases, conjunctival exposure leads to thickening and keratinization. There are certain tests for lid laxity. Horizontal lid laxity is assessed using snapback test. Then there are tests for lateral canthal tendon laxity and medial canthal tendon laxity. To assess horizontal lid laxity, gently pull the central part of the lower eyelid away from the globe. Measure the distance and recoil. In a normal lid, it should snap back immediately when released. If the lid can be pulled 8 mm or more and fails to return to position unless the patient blinks, this indicates significant horizontal lid laxity. Lateral canthal tendon laxity is assessed by pulling the lower lid medially and observe the lateral canthus. In normal patients, the movement is minimal. If the lid can be pulled more than 2 mm and the lateral canthus appears rounded instead of sharp, this indicates lateral canthal tendon laxity. Medial canthal tendon laxity is assessed by pulling the lower lid laterally and observing the position of the inferior punctum. In a normal eyelid, the punctum should not be displaced more than 1 to 2 mm. If medial canthal laxity is present, the inferior punctum may move excessively. In mild laxity, the punctum reaches the limbus, while in severe cases, it may be displaced all the way to the pupil. In involutional ectropion, the primary abnormality is horizontal lid laxity, often associated with lateral canthal tendon laxity. The mainstay of treatment is horizontal lid tightening, most commonly achieved using the lateral tarsal strip procedure. The lateral tarsal strip procedure is particularly effective in patients with generalized ectropion, horizontal lid laxity, and a rounded lateral canthus. It tightens the eyelid and restores the normal apposition to the globe. Mild medial ectropion with punctal eversion can be treated using a medial conjunctival diamond excision, also known as the medial spindle procedure. This is frequently combined with a tarsal strip or lateral canthal sling or pentagon excision, as significant horizontal laxity frequently coexists. When medial canthal tendon laxity is marked, it must be corrected before or along with horizontal lid tightening. Failure to do so can result in excessive punctal displacement and persistent watering. Any condition that causes skin contracture can lead to cicatricial ectropion. It is caused by scarring and vertical skin shortening. It pulls the lid away from the globe. The key pathology is vertical skin deficiency. The causes can be trauma, burns, previous eyelid surgery, dermatitis, and ichthyosis. There are certain clues that help differentiate cicatricial ectropion from involutional causes. In cicatricial ectropion, the ectropion improves when skin is pushed upward. Mouth opening may exaggerate eversion. The treatment options are release of scar tissue and vertical skin lengthening, setplasty, and severe cases require skin grafts to correct vertical deficiency. Paralytic ectropion is commonly seen in Bell's palsy or after acoustic neuroma surgery. It is associated with retraction of the upper and lower lids and rhotosis. Complications include exposure keratopathy due to lag of ophthalmos and watering caused by malposition of the inferior lacrimal punctum, failure of the lacrimal pump mechanism, and increase in tear production resulting from corneal exposure. Temporary treatment is indicated in acute facial nerve palsy such as Bell's palsy or post-surgical nerve injury where spontaneous recovery is expected. Mild cases can be managed with conservative measures including frequent lubrication during the day, ointment at night, lid taping during sleep, and moisture chambers to prevent corneal exposure. Botulinum toxin injection into levator palpebrae superioris can be done to induce temporary ptosis. This reduces exposure and provides corneal protection during the recovery phase. Temporary tarsorrhaphy is indicated in patients with poor Bell's phenomenon or severe corneal exposure. The lateral portion of the upper and lower lids are sutured together to protect the cornea. Permanent treatment is considered when there is irreversible facial nerve damage such as after acoustic neuroma surgery or when no improvement occurs after 6 to 12 months in Bell's palsy. Permanent correction involves a combination of procedures depending on the defect. Medial canthoplasty may be performed if the medial canthal tendon is intact. The eyelids are sutured together medial to the lacrimal puncta so that the puncta become inverted and the fissure between the inner canthus and puncta is shortened. Lateral canthal sling or tarsal strip may be used to correct residual ectropion and raise the lateral canthus. Upper eyelid lowering can be done by levator disinsertion. In patients with lag of ophthalmos, either gold or platinum weights can be implanted into the upper lid. Platinum weights are preferred because they are less bulky than gold weights, provide a better eyelid contour, and are less likely to need long-term revisional surgery. A small lateral tarsorrhaphy is usually cosmetically acceptable. Mechanical ectropion is caused by lid tumors or masses. The weight pulls the lid margin outward. Treatment involves removal of the causative lesion and correction of residual lid laxity. Some exam relevant points are: the most common type is involutional ectropion. Horizontal lid laxity is the key pathology. Lateral tarsal strip is the main surgery. Cicatricial ectropion needs skin lengthening.